welcome to the Safety Leaders Update of whether health information technology is evidence-based. We're delighted to have our attendees on that are on real time, and a number will be on our demand portion due to the holidays, and we're just very grateful to have you attending our program. First off, on slide 3, I just want to remind everyone to turn their computer volume up to the highest level on their machine. And if you still have any audio problems, please go ahead and click in the participant section and the telephone icon to request phone, and that way you'll get better audio, and we'll give you a phone line. On slide 5, and for those that don't have slides, go to safetyleaders.org, www.safetyleaders.org. In the upper right-hand corner under upcoming events, you can click on this date's webinar, and that will lead you to the page to download the slides and a session overview where we'll put future content as well. On slide 7, our addresses for social media are noted there. And then on slide 8, our purpose statement, we will measure our success by how we protect and enrich the lives of families and patients and caregivers. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve. And our disclosure statement is on page 9 of the slide deck, and no product, service, or technology for which anyone has any relationship will be addressed. We have Ross Koppel, who will be briefing us today on health information technology, a great passion for him. Jennifer Dingman is our patient advocate, and I'll be coordinating things. And I'll turn things over to Jennifer to give us our welcoming statement and help us get grounded in what we're doing. A longtime patient advocate, a published author in the medical literature in patient safety, a contributor to the National Quality Forum Safe Practices patient section for including and involving patients and families, and a terrific champion for patient safety who is a co-founder of PULSE, which is the Persons United Limiting Standards and Errors in Healthcare. Jennifer, would you please open us?
Thank you so much, Dr. Denham. It's a pleasure to be here today. Health information technology is very, very important to patients and families. This webinar is going to go into the details about that, and this is so important for all providers to learn and understand. Also, patients and families like myself. I want to thank you all so much for being here today and encourage you to please share this webinar with your colleagues after it's recorded. Thank you so much, and this is exciting. I'll hand it back to you, Dr. Denham.
Thank you, Jennifer, and we really appreciate your constant support. I'll open with just a quick news update and the results of our October webinar polling and focus on mortality reviews. A few things in the news. The HIPAA compliance issues holding back health data exchange, and we know that this is a big challenge, and the misunderstanding of HIPAA hopefully will be clarified in 2017, and we're looking forward to a lot of changes that may open up the opportunity for us. In the Annals of Internal Medicine, an article was published by the researchers at Baylor College of Medicine addressing diagnostic errors and 5 dimensions of diagnosis: patient-physician encounters, performance and interpretation of diagnostic tests, follow-up and tracking of diagnostic information over time, subspecialty consultation-related communication and coordination, and patient-focused strategies. And we know that this is an area that a lot of organizations are starting to focus on that would land in the errors of omission. Also, just released on the 16th, yesterday, the AHA is pushing Congress for relief of meaningful use. And so this will be important, and we'll have to keep watching that to see where that goes. Another update is on the MedTech program, which we've discussed in prior webinars, the focus on the leading causes of death of otherwise healthy people that are actually children K through 12 and adults in our workforce. It focuses on the leading causes of death in otherwise healthy people and the lifeline behaviors that we could focus on: cardiac arrest, choking and drowning, opioid overdose, anaphylaxis, active shooter events. Now we know that there's at least one a week that occur in hospitals or healthcare organizations, non-transportation accidents, and on-site transportation accidents at a facility. Bullying is a contributor to that in schools, and so this program is really taking on a life of its own. One of the areas that the active shooter events has prompted is a terrific program sponsored by the American College of Surgeons, and that is the Stop the Bleed program. Take a look at slide 17, and you'll see that there is a good PSA that's available on the web that you can share with your colleague. It will not be surprising to find that many organizations are now putting Stop the Bleed kits of tourniquets and pressure bandages where their AEDs are, their automated external defibrillator devices are. So now moving to polling, Dr. Jean Huddleston from the Mayo Clinic has done a terrific job over a series of webinars addressing what we can learn from the 10,000 deaths, sequential deaths at the Mayo Clinic, and really given us some great insights. Her slide on slide 19 showed the numbers of errors of omission or issues of omission versus commission, and we've all been focusing on medication management and supervision and a number of areas, including infections. But if you look to the left of the axis, you see that diagnosis is number one, followed by resuscitation and failure to rescue. So we'll have continuous continual webinars focused on these topics. We wanted to give you an idea of what our anonymous polling showed, and we asked the question: I am interested in all-cause harm approach, integrating mortality reviews for patient safety and risk management. So this is an all-cause harm to both patients and those who serve. 47% of you gave that a 10, 93% agreed, with 74% strongly or very strongly agreeing to that. This tells us that we need to focus on this, and we will in 2017 if we don't focus on it in our December webinar. We had a free text entry question regarding all-cause harm topics you'd like to be covered, and you can see medication issues, COPD, sepsis were very, very common areas. Also misdiagnosis, which is, as we said, a very hot topic. The second thing that we interviewed you about was regarding the care of those who serve, not only those we serve, but those who serve. And if you remember the story of Eric Kropp, who was the pharmacist sent to prison after the death of a child due to an unintended systems-grounded medication error that we showcased in the film, the Discovery film that went global called Surfing the Healthcare Tsunami. The second case was that of Julie Tao, the nurse who, again, made an error, an administration error that led to a medication error that led to the death of a 16-year-old young mother, and who was indicted, didn't go to prison, but was barred then from working at healthcare institutions for 5 years. Dedicated nurse who accepted the blame of this issue. However, these issues we know, and our medical and our professional and nursing credentials are being threatened after an error occurs. So we asked the question: I am interested in a webinar addressing the latest update on errors and caregiver blame, including nurses and doctors and all caregivers, and HR issues. And we had a very high response to that. 51% of you gave it a 10, 86% agreed, 63% strongly or very strongly agreed. The topics that you wanted us to address are up: bullying, blame, staffing issues, a host of these areas that we know are big challenges and which were uncovered by the study done by the Agency for Healthcare Quality and Research. Another element in the news, and a topic that Ross will be covering here shortly in a few minutes, are electronic medical errors. And we draw your attention to this Huffington Post publication and a 2016 study that identified the growing frustration with EHRs, and with the report that physicians were spending almost 2 hours each clinic day for every hour of direct face-to-face time with patients. So that frustration with the EHRs is definitely addressed. We asked the question, I am interested in a webinar addressing the latest update on electronic healthcare records and H.I.T errors and harm. And again, pretty strong response, 44% at 10, 62% strongly, and 44% very strongly agreed. So we are going to follow up with that. The topics that you gave us, you can see copy and paste, very, very common issue, and a number of topics that I won't read off of the slides because we'll move to Ross, but you can see that a lot of you are having the similar issues, also including cybersecurity. So our real focus now is to have Ross address an area that is very close to his heart, and this is health information technology evidence-based. He is a widely published author in this area with academic appointments and multiple collaborative initiatives. He's been a multiple-time speaker to our audience and has really provoked us to really focus on a number of issues. He's an adjunct professor of sociology at the University of Pennsylvania and also has an appointment at the Wharton School. Ross, we'd like you to address this topic, please.
Good afternoon. I'm Dr. Ross Koppel. I'm going to ask the question, is healthcare information technology evidence-based? And next slide, you can see that I can't keep a job. I've been doing a whole bunch of things at the University of Pennsylvania. Plus, I've been working in cybersecurity as of late for the NSA. Just definitions by H.I.T, Healthcare Information Technology, means CTOE, E.H.Rs, E.M.Rs, BCMA, but mostly E.H.Rs. Now, there are some uncontested, wonderful benefits, and there's a special place in hell for people who read slides to literate audiences. So I'm going to try not to do that. Also, we have a little bit more text than we have time. So I've been informed that you guys can get a copy of these slides and look at them at your leisure, which is a very good idea because I'm not going to have time to read all of this. But as you look at these, you can see that in addition to all of these benefits, there are some assumptions. And those assumptions are that we would have available to us the ability to mine these oceans of data if we had data standards and interoperability. Tragically, that word "if" is still uncertain. Now, next slide, we're saying evidence of what? And I'm clicking through these so you can see the issues. And a lot of this deals with usability and navigation. Do you know where the heck you are when you're using the system? Have we used human factors research? We'll return to that. And then we come to the issue of, have vendors used full human factors level testing? And the answer is no. There was a recent article in JAMIA in which the vendors reported on what they did for testing of usability, and it was about 1/1000th of what is recommended. So instead of testing the various screens in the many different settings, sizes, different types of clinicians, they used about 6 people, some of them. 3 of the people were secretaries who knew nothing about business, about healthcare, but were in the shops. One was the guy who developed the system. Another was a random stranger. And then there was one clinician, maybe one nurse and one doctor. This is hardly what's required. You're supposed to do a minimum of 15 people in each setting for each type of use. Next slide. Evidence of what? And again, I'm not going to read these, but the critical issue here is, do we evaluate the system or the implementation? By implementation, do we mean the hundreds of different types of implementation? This is all critical for what we mean by evaluation. And then some of the listings of stuff. When do we evaluate? The 5 months after go live, 5 years, whatever. And then finally, we have to recognize that the possibility of random clinical trials for H.I.T. is a pipe dream. I mean, imagine, as a thought experiment, we installed in one hospital, half of the hospital got Cerner, the other half got Epic, and we blindfolded all of the doctors so that they wouldn't know what they were using. That, of course, is murder and psychotic. The point is, we can't do that kind of RCT in a healthcare setting. And now we ask evidence of what? And we're looking at CDS. And I'm just going to click through these. And again, I urge you to return to these. This last point, and the red is more as a clue to me, to remind me to talk about something. I did a small survey of hospitals, and I asked hospital CMIOs how many systems are connected to your E.H.R. And the answer varied from about 150 to 800. The 800, the guy was probably thinking of every smart bump, but let's ignore that one. The point is, there's a heck of a lot of stuff that's connected to the E.H.R, be it outside labs, the pharmacy IT, various vendors involved with buying and selling stuff to the hospital and the like. And then there's all of the internal stuff about the PACU connected to different units and the like. And in a sense, each of those units sometimes connects within itself to other units within the hospital. So actually, if there's 150 devices connected or systems connected to the E.H.R, and many of them are connected to each other, it is conceptually, although way over-based, would be literally 150 squared connections. So each one of those is a vulnerability and an opportunity for confusion, and also a cybersecurity vulnerability, by the way. Next, look at some of the stuff in CDS. Now, next slide, evidence of interoperability. Well, you know, that's the holy grail that we just don't have. Next slide, evidence of improved patient safety. Well, first of all, patient safety is a heck of a difficult thing to operationalize and measure. In a sense, as I've said in one of my books, it's the absence of not screwing up. And so we have one for that absence of screw-ups, but we'll continue on. And remember, I'm professor of research methods at the University of Pennsylvania, so I really care about how we measure stuff and how we go about accessing the data that will support this. And are there systematic data? And then there's the whole question of return on investment. How the hell do we calculate that? Do we do it after 3 months, after 3 years? Do we do it in terms of fewer staff, errors avoided? I'm reading slides. I promised I would never do that. And is the ROI a sort of post hoc justification for having spent a stunning amount of money on the H.I.T and then the implementation process? And by the way, determining the cost of H.I.T, when you include all of the training and the linkages and the retrofitting and the millions of dongles that are required and the low productivity and the setup, calculating the cost is a Herculean task that very few wish to undertake, especially those whose jobs are dependent on saying, look, we did a great job and the system came in with a good ROI. Are we controlling for all of the factors that affect an implementation and productivity? Here are some of the literature, and I've purposely made it too small to read unless you really carefully look at it, but you can. And these end about a year ago. There's been about 40 publications on this supplement each month. Okay, so to be fair, whether or not we have good evidence of the efficacy of EHRs and the like doesn't mean that they're not wonderful. We've had perfectly good bridges before we had trigonometry and advanced physics. Measuring the effectiveness and the failure to do that is not proof that they're not wonderful. And indeed, they have so many wonderful benefits. But let's look at some of the evidence, and let's look at some of the bias involved in the evidence. Now, this first study by H.I.T, was the critical one that appeared in the New England Journal of Medicine. And it asked hospitals what they needed so that they could buy and use EHRs. And what the hospital said was they needed more money. They needed tech support, objective evaluations, and the list of certified vendors. Remember, this is 2009. And this was the touchstone of everybody's understanding of what it was that justified MU, meaningful use. But a year or two after this, I got a copy of the questionnaire. And I looked at it, and I was stunned. There were no questions, and thus no findings, obviously, about usability, patient safety, interoperability, data standards, or the nightmarish interfaces. In other words, what the questions were asked, and I'm sure they were sincere and valid in their attempt, was a reification of their beliefs about what was needed. And what they found was just proof of their own subjective views of what was needed. It's not good research. Interestingly, the anchor author of that paper by H.I.T was in fact the subsequent director of the ONC, David Blumenthal. So they concluded that doctors and hospitals were technophobes and they needed money. Not my view. So let's look at meaningful use. We all think that meaningful use somehow developed in 2009 to ensure, justifiably, that if the government was going to provide $32 billion in subsidies, that the government should insist that the systems were used meaningfully. That made sense. But we think of it as having developed in 2009. In fact, the plans for meaningful use, the enforcing of certain forms of purchasing, had been on the books at HIMSS and at AHRQ for 20 to 30 years before 2009. This was a plan that was shovel-ready in the most fulfilling way of that term. And then I was attending one of his meetings at AHRQ, of which I'm very deeply involved, and the chief lobbyist was saying this, and I was stunned, and I let you read that yourself, appears to enable patient safety. This is from a report within Cerner by a strategist at Cerner, in which he suggested that they would use MU as a way of excluding some of the other vendors and playing with the government to make it barrier to entry to others. More importantly, perhaps, is the famous RAND study of 2005 in Health Affairs. And this study was also a touchstone of everything that was used to justify EHRs. And it said, if you read it carefully, that if we used EHRs, used them well, we would save more than $81 billion a year due to higher efficiencies of EHRs. And this would be fabulous. And this was quoted by everyone constantly. But let's look at the next slide. And we see that 8 years later, the authors from RAND, for which they should be congratulated, Kellerman and Jones Jones, by the way, was my RA on a previous, and co-author on a previous study, they published a remarkable paper that said, well, it didn't happen. In fact, rather than go down by 81 billion a year, it went up by 800 billion for that time. And they also then said, why is this the case? And rather than say the systems are mediocre, the E.H.R. systems, they said, well, we haven't adopted that much. They also said that hospitals chose to buy systems that are neither interoperable nor usable. That's a crazy statement. And then, of course, the failure of healthcare providers to change their workflow to take advantage of the systems. So, whereas they admit it didn't come true, they nevertheless somehow blame you. Now, they do say, in explaining why the promise was not met, they look at some of the issues and they blame what I would say is not the fault of providers. They say we needed standardization, interoperability, patient input. All right. And then providers have to re-engineer what they're doing. And then they throw in at the end, well, I guess we need value-based payments and maybe single payer, which is an interesting thing to throw in. They note that the CBO found that their estimates were completely off the wall. And they also note that their study is nevertheless cited by everyone and is the touchstone of all decision-making. And now, voila. In the 2013 report, they highlight something that was obscured in the original report, that RAND was paid by Cerner and GE and other IT product providers to produce this study, saying that that money would be saved. And they call it something like support and guidance. Interesting. One of the other interesting aspects of seeking proof of E.H.R.'s efficacy was the ONC's request for stories about how wonderful everything was. And the ONC, this was a literal quote, was seeking videos of how E.H.R.'s improved care. Well, that's valid, that's good, that makes sense. On the other hand, do we learn a lot by only looking at success stories, or do we learn a lot by looking at success and problem stories? I leave that to you to decide. So, let's return to the question. Is it evidence-based? We don't know. It's incredibly difficult to come up with answers to this. We know that a lot of the evidence has been hyped because the fear of medication error, of medical error, and the desire for EHRs, which are so wonderful, has colored our views of what we're looking at. But as I've argued methodologically, it's very, very difficult to get at these measures. I'd also say there's a lot of fuzziness in how we go about measuring this and how we go about thinking about those measures. And there's an awful lot of conflicting information out there. Yes, it certainly speeds everything. It certainly has dramatic advantages, but there are also downsides. And the vendors tend to emphasize the advantages, and informatics scholars tend to emphasize the, well, I would say balanced view, but they would differ. And last, there's the blinders of looking at the positives, because if you've invested $1 billion in an E.H.R. and implementation, it's not in your interest to look at the problems. Furthermore, the whole gestalt of the vendors and of the ONC, to be perfectly honest, was to sell this stuff, to push it because of noble motives that they believed that EHRs were so much better than anything else. And they are better than anything else, but are they anywhere as good as they could be or should be or must be? Last, there has been real recent progress. The ONC is recently requiring we're talking about evaluation in situ. So if, in fact, as the vendors have insisted, most of the screw-ups come from bad implementation, this would capture that. And the OMC recently issued a guide to contracts, useful guide to contracts. It doesn't have everything I want, but it is thoughtful, and it will help hospital CFOs negotiate contracts with vendors of H.I.T. And recently, there was an article in the Journal of Patient Safety that looked at the errors associated with H.I.T. using malpractice claims. Now, the reason I have Kathy Kenyon in red there is that Kathy was a top lawyer for the ONC, and as recently, she's now departed, I believe she's retired, but my last conversation with her, she insisted there was no examples of problems, or so few, with the E.H.R. of patient safety issues. And yet I am enthralled to see her as an author on this paper. So there is a willingness to look at all sides. The SAFER guides by my friends Hardeep Singh and Dean Siddig, while I have problems with them because they are insisting that somehow we can learn so much from reported errors, when in fact we probably only know about 1 or 2% of medication errors associated with EHRs, because if you know you're screwing up, you fix it. It's the ones that we don't know about that reach the patient and are harmful. And it's very hard to determine that harm. I mean, patients are old, they have comorbidities, they're taking 13 other drugs. Medication error, which is by and large the largest category of medical error, is very hard to determine in the reality of patient care. But nevertheless, the SAFER guides are a true benefit and are suggestive. And there's more stuff coming out that looks at a more balanced perspective. So in conclusion, and you should always say that, it gives the audience hope, we have this desire to use EHRs to save us, and they offer tremendous advantages. I'm not suggesting that the manufacturers of EHRs had anything but honorable intentions, at least to start. But of course, there are firms, some of them multi-billion-dollar firms. But there was a limited vision. They didn't want to look at the problems as much as they had to. Again, I end on positive movement that we're seeing a more balanced approach, and we're building on it. And I thank you, and I hope that this has been of some interest. Thank you very much.
So, Ross, we really appreciate your contribution, and we have a series of questions that we've actually recorded and asked Ross to address, and I think that there is a terrific opportunity for research in this area. We're going to do our polling right now before we ask Ross a series of questions that we would like him to answer. But the first, coming back to the beginning of our the session, we talked about the medical tactical emergency response topics. Would you like a deep dive on these leading causes of death to your patients, the healthy patients, and the healthy caregivers in medical institutions? So these were the top 7 causes of death, and what we can do to implement them, including active shooter events and stop the bleed programs. And the safety topics that you'd like to have covered, please put them in the free text entry section. So the question is, I am interested in an update webinar on medical tactical emergency response topics, and that would include the active shooter events, opioids, sudden cardiac arrest, anywhere on in your facility, anaphylaxis, choking, and the other topics of interest at facilities, and the safety topics you'd like to address. The second polling question is, I'm interested in a webinar addressing how caregivers protect their professional identity after an accident. So after a healthcare accident or incident, an adverse event occurs, a webinar on how caregivers specifically, because they're put at odds with their organization, how can we help caregivers who are the second victims of such accidents protect their professional identity and the professional liability of their identity, and the topics regarding the professional identity protection. And so this is your H.R. file. This is what can happen after a bad event occurs when the blame game starts to ensue in some organizations, and how we can, what topics that you would like to address in that area. The next question is, I'm interested in a webinar addressing the latest update on conflicts of interest and financial disclosure. We'd like to know, this is becoming an increasing insider issue and problem at organizations with the advent of the internet, transparency, the whistleblower programs. It's critical that highly ethical people are not vulnerable to perceived conflicts of interest when they have been doing everything properly. And so we're trying to kind of be able to flesh this area out. And the topics of interest on conflicts of interest and financial disclosure that you would like to have covered are, and please add them. So what we'll do now is we're going to ask a series of questions of Ross to specifically allow him to give them to us and kind of a package, their modular answer. When push comes to shove, do you believe there is evidence that H.I.T. really delivers?
Well, Ross, many thanks for being with us today, and we know that you're doing major briefings around the country and in Washington regarding this area of health information technology. So I have 5 or 6 questions I'm going to ask you because we have the time to do so, and would love to just give you whatever time you'd like to answer the questions. The first question is, when push comes to shove, do you believe there is evidence that H.I.T. really delivers?
Well, I've just spent 20 minutes saying it's a damn hard question to answer, and it depends how you define it and how you measure it. But when push comes to shove, the answer is still wishy-washy compared to what you'd like. The answer is it delivers many wonderful things, but whether it delivers what we want in terms of increased patient safety, in terms of economic savings or faster work with patients, the data are equivocal. They are genuinely equivocal. It does, things that nothing else could do. We can mend the data. We can instantly have it available on 1,000 different screens, 1,000 different doctors who can communicate and talk about it simultaneously. The information is ubiquitous and instantaneous. Reports to the information to the pharmacy is sent electronically. All of that is wonderful. But whether we have increased safety or not, given the issues and the problems with EHRs, the answer is it produces many safety advantages and also introduces certain safety risks. And so I'm going to punt. I'm not happy with that, but that's the reality.
Well, thank you for your candor and honesty regarding that. The second question, and I'll take these in an order to help our safety leaders. You and I were very concerned when a committee was assembled and made recommendations that the IT vendors and the E.H.R. vendors should provide a list of risk areas that this be made non-burdensome. And when the final committee report came out, it said that they should not be made not burdensome, which basically gave them a buy. Has that changed, and are they providing us with risk areas, and do we have something to go on directly from the vendor community, or did they get a complete buy because of this malfunction of the committee?
Well, the committee would say responsive to commercial interest, not malfunction.
So the committee, so just to clarify this was written about, they felt that it was conflict of interest that drove a change in what they recommended.
I would say that the ability of vendors not to be fully forthcoming on the risks of something as intimately involved with patient safety and with all patient care as E.H.Rs is disgusting. How's that for a non-equivocal answer?
So really, there's nothing new there, and that really stood.
But there have been some recent movements about being more forthcoming, but I don't know where that's landed, and I don't know how the new administration will respond to that.
Gotcha. So my third question is, what message do you have for our frontline patient safety leaders regarding H.I.T? These are the patient safety officers and the quality officers for which patient safety is in their wheelhouse.
Right. So the first lesson is that if they think that because they've introduced an E.H.R. that they have improved patient safety, the answer is unequivocally no. If they think they have improved some aspects of patient safety, the answer is yes. But they have to recognize that they have introduced new dangers and problems. I mean, my 2005 article was entitled 22 Errors Facilitated by E.H.Rs. So the answer is there are different patient safety problems, and those problems have to be carefully examined. And the E.H.R is a mixed blessing in that not only does it provide greater efficiency and a greater opportunity to see some of the errors, it also obscures some of the errors. And so it remains a different animal. And so just like, a horse is faster than a human in terms of getting from point A to point B, but introduced additional threats and errors or dangers, the E.H.R. introduces additional threats and errors. And I would urge people to read constantly about unintended consequences. And by the way, the new International Journal of Medical Informatics Yearbook has a special section on unintended consequences of H.I.T. And I was fortunate to be the editor of that section. And I don't know if it's available for free or not. I think JAMIA members can get a copy. But it's well worth looking at that and some of the other information in that annual review. I think the patient safety people who I admire and who we all depend upon to stay alive have to increase their vigilance, not only for the usual patient safety issues, but also for the patient safety issues introduced by this wonderful technology.
Well, thank you. That is a great answer. And I'll put one more question in place. There are the unintended consequences and no real formalized reporting system for us to understand, aggregate knowledge regarding errors or regarding issues the way there is in aviation. Do you think there is a place as the IOM and now the National Academy of Medicine, but during its tenure called the IOM, recommended that there be an NTSB for healthcare and that this could really help? And, we have written articles about this and believe those of us from an aviation, dual medicine and aviation background, that such a program could help quite a bit if we could take very important events and be able to do a deep dive to understand what we could learn from them so they don't happen broadly. Do you think there's a place for such an entity?
I'm going to give you a very surprising answer. Not much of a place, and I'll tell you why. When a locomotive crashes into another locomotive, we have a smoldering ruin, we have dead people, we have a recorder look at what happened and all of that. So yes, when there's a catastrophic failure, the E.H.R. Confuses all patient records and sends the meds to all the wrong patients. Sure, an NTSB type deep dive is required, but 99-point-something% of all errors don't have the evidence for them. As I said earlier in the discussion, patients are old, they're sick, they've got 5 comorbidities, they're taking 13 other drugs. The young doctors who are prescribing in a teaching hospital are trying to figure out how to use the system, which is clunky. They're trying to figure out how to be doctors. We don't know the vast majority of the errors that we make. If a doctor or a nurse makes an error, he or she fixes it immediately and it doesn't reach the patient. We know about those. The ones we don't know about are the ones that harm the patients that we almost never know about. So having a whole bunch of guys in hazmat suits and clipboards coming in to examine what we don't know about is a logical fallacy. So I'm really apprehensive, and that was my problem with CITIG and SANE, my friends, where they called it this NTSB type thing, information error, but it's looking for the stuff that fell through the cracks, and you know, hazmat suit clipboard doesn't find that.
Great. Well, that makes a lot of sense. You know, the takeaway there is that there are such a vast array of them that it may not, such a study may not be applicable to, and then there may be that are some. So, and we know with the NTSB that it's only a small fraction that they actually pick to do. Let me, just for time, go to the next question, and this is one that is really pertinent to you and I, because we know what a great role that board members can, the untapped power of board members. What message do you have for our governance board members of organizations, those representatives from the community who actually ultimate call on where resources go and can ask the tough questions?
You know, Chuck, I've been doing this now for full time for, 15, 20, 30 years, and that's the first time I've ever gotten that question, and it's a critically important question. So there are a few things. One, recognize that almost everything said about ROI is total nonsense. As I've tried to articulate in the presentation just now, we have no idea what the ROI is because we have no idea what the various measurement factors are, how to measure it, and all of that. That's part one. Part two is that the board has an obligation to keep people honest by saying, look, guys, I know the CMIO and the CFO have put themselves on the line by spending billions of dollars on these systems, and I'll explain what I mean by billions. And of course they don't want to announce that their baby is ugly, or they've had problems with X, Y, and Z. Cognitive dissonance makes it almost impossibly to objectively look at something that's taken you 5 years of your life and $1 billion to implement. And they have to likewise recognize that it is so self-destructive to punish nurses and doctors who point out problems with the E.H.R. But that's what happens in so many of the cases. People are so invested in these systems that they cease to be able to hear the problems with them. I mean, you know, doctors want to do good medicine. They don't actively seek to hate the tools that they use. They don't walk around screaming and telling you how stethoscopes suck and ruin their lives, or even how MRIs or X-rays ruin their lives. They love the equipment that helps them be better clinicians. But with E.H.Rs, so much of the system so much of the interfaces and the like are so clunky and user hostile that they become sources of frustration and rage. So the board has an obligation to tell the people who have actually implemented these things, look, guys, rather than punish people who talk about the problems, listen to them, and you should try to address their concerns. They didn't become clinicians just to fetch about EHRs. They became clinicians because they wanted to treat patients. And if they're complaining about it so much, why don't you pay attention to what's happening?
Fantastic. Such an important message. Thank you for that great answer. So the next question is, what questions should we ask as those of our audience that are patient safety leaders, quality leaders, and administrative leaders of their IT leadership, of those that are actually running the systems, putting the systems in? Are there important questions that we should be asking them? We tell our audience that in the early phases, IT is 90% T and 10% I. As they mature, we want to get more and more information out of them, and the role will change to 90% I and 10% T ultimately, as it has in so many other industries, but we're in this transition. What questions should we ask of our IT leaders that are putting the systems in and getting them up and operating them?
Well, the first is, one, are they prepared to do the immense amount of work? I'm working with a lot of CMIOs who are critical players in the implementation process, and very often the vendors have told the IT department that they're going to help them tremendously and that they don't need as much work as they think. In fact, in all cases, that's not been the case, that the IT department has had to expand exponentially to deal with the implementation, to deal with the linkages, with the order sets, with the connections, and recognize that the EHRs, as magnificent as they are, and because of that, rather, they're so magnificent, they have millions of moving parts and interchangeable parts. And so you fix one thing, and all of a sudden you can't order bandages for 2 weeks. There's so much involved. They are so complex that the IT department is put upon in ways that they couldn't possibly imagine. So the first question is the IT department staffed up with experts and the like to handle this? The second thing is recognize that the IT department's needs will be expanded, not cut by the new system. And then remember also that problems are always emergent. Patient loads become different. Clinicians differ in skills. New medications, new treatments are available. And all of that has to be reflected in the EHRs and other devices. So if you solved a problem and you think you can sit back, you're a fool, because the problems are always going to be morphing and emerging. Some will go away, new ones will appear that are very different. And then also the IT department has to recognize that they should not be regarded as the enemy of the clinicians, but rather as working with them. And very often there's an us versus them attitude that develops that's toxic. There's another point that you didn't ask about, but I'm going to introduce because I'm so involved with it, is cybersecurity. Often that comes down to the IT people. And the IT people are hated for it, but with all of the hospitals facing ransomware, with hospital data being the most attractive to break into, this is critical. And so, again, clinicians have to work with the IT department in ways that make sense for security. And if you increase security so that nobody can do anything with the damn system, then you've been counterproductive, and everyone will find workarounds to it.
Now that you've addressed that, and thank you for taking the time for these are very thoughtful answers. You know, the CIO of the White House said that in 2016, 1 in 3 medical records will be breached, that we know that an enormous number will be contaminated by thieves that use them to extract money out of the ecosystem, and that probably less than 20% of organizations have any sort of system to help a patient when their record is contaminated to get it back reflecting their accurate medical identity. You know, any comments regarding that? They're precious to organizations. They're actually helping patients, and the estimate is that 1 in 3 lose their healthcare insurance because of the contamination.
Well, the answer is so complex. Health data are worth on the black market as much as 6 or 7 times more than on the black market than, for instance, stolen Social Security and credit card numbers. Why? One, healthcare data already has your Social Security and your credit card information. 2, the data are useful for blackmail. And 3, and most important, in the hands of unscrupulous providers, they can then bill insurance companies and CMS for literally billions, as some unscrupulous providers have done. And when they bill CMS or whatever, they know exactly what's wrong with the patient and what services or treatments made sense. So it makes it really hard to identify. I have an article available for free recently in the healthcare blog, Teach CD, co-authored with my friend Jesse Walker. Jesse was the chief cryptographer for Intel for 25 years and invented WPA2. So I urge people to take a look at that, where we try to articulate some of the problems. And as I said, it's available for free.
We'll post that so that folks can download it for you. That's great. Now, just 2 more questions, and we've added to our questions because your questions are so thoughtful. What is your take on consumers having access to their medical records through portals that are made available by healthcare systems?
Well, I'm giving a paper, I'm giving a session at JAMIA in 5 days on direct consumer information going into PHRs and EHRs. And on the one hand, it's wonderful, and we want everybody to take advantage. On the other hand, you know, if a doctor gets a call at 4 o'clock in the morning saying my bun has moved up from point something to point something, and the patient's hysterical, and the doctor says it's irrelevant, that's not going to make anybody happy. The problem with patients is that a lot of them are very sick and are not physicians. And so reading a lot of that information sometimes produces the equivalent of medical school student disease. Nevertheless, obviously, we want patients very much to have total access to their records. We know that they're building in certain forms of protection. So, for instance, a dire test result should be delivered not via an email, but with the intervention of a skilled clinician who can help interpret that. I mean, you don't want an email saying you have stage 4 cancer. The average patient wouldn't know whether it's cancer that's going to kill them in 2 weeks or something that's deal-withable. So we have to think about that. Not all transparency and instant availability is beneficial or potentially beneficial. On the other hand, we desperately want patients to be able to see the record. We know that when patients see the records, they correct screw-ups all the time. And the same thing holds true for patients seeing the E.H.R in the doctor's office. We have tons of examples where the woman will look at the doctor and say, no, I had 4 pregnancies, but I only have 2 children. depending on the patient, that could be a crucial piece of information. Anyway, so in general, it's wonderful, and we want to encourage it. On the other hand, there's stuff like people having Fitbits and data like that feed directly into their EHRs, and that's scary as hell. I have tons of examples of Fitbits that have been attached to ceiling fans, electric drills, and dog collars. Now that is going to give quite a deceptive reading of the patient's activity level.
Well, so then final question, and you've been so generous with your time, and we really appreciate you recording this with us because of your commitments in Washington. The last question is, what impact do you believe the new administration will have on H.I.T? And you and I had a preparatory call when, that's kind of hard to determine, that things regarding HIPAA, ONC, and, this endless array of regulatory issues and performance issues in a new area. Any idea what the new administration will now do or have impact on?
I have absolutely no idea. I know that HIPAA is confusing as hell to most people. When I talk about HIPAA and I'm presenting slides and I say HIPAA is whatever the person in charge of the office thinks it is. And we are all horrified when HIPAA is used as an excuse to avoid portability, because that P, by the way, stands for portability, and people use it as anything but, the exact opposite. Talk about unintended consequences. On the other hand, we want the protections of HIPAA used intelligently, just not used stupidly. Everybody, Democrat, Republican, has been enamored of this technology from the get-go. And so you're not going to find, I think, a belief that it should be done away with. On the other hand, if everybody regards all regulation as a pain in the neck, including whether you should drive on the left or right-hand side of the road or both sides of the road, we're going to have a lot of dead patients and dead people. We need certain forms of regulation, and certainly the kind of transparency we want for medical informatics would benefit from good regulation. On the other hand, we've seen examples, as we discussed a few minutes ago, where the regulation is used to obscure transparency. So obviously, I have no idea where this administration is. I've been, frankly, crying since the early morning of November 9th, and I don't know.
Well, Ross, listen, you've been so generous with your time, and I know this is an evolving area, and we really appreciate you helping all of our quality and safety leaders across the country, and for those that are outside of the United States as well. So thank you very much. We really appreciate it. Excellent job, and thank you for keeping us up.
Thank you. Have a wonderful day. Bye-bye.
So we're very appreciative of Ross Koppel. Had to drop off because he is briefing the Office of the National Coordinator in Health Information Technology today. And so if you would like to submit any of your questions in the Q&A section, we'll follow up with Ross to address them. And we really appreciate your attendance today. We are going to finish the webinar up early. We'll hear from Jenny Dingman to close the webinar, and today's webinar will offer 1 hour of continuing education credit due to the fact that we'll end a little bit earlier and send you off to Thanksgiving break. We'll have another webinar in December, third Thursday of the month, and we'll adjust our time according to the holiday schedule. But we will have a December webinar. Thank you very much for attending, and Jenny, would you please close us?
Thank you so much, Dr. Denham. As always, this webinar has been inspiring and educational. Again, I want to thank each and every one of you personally on behalf of all of the patients and families that I talk to all the time, that I work with. Thank you so much for caring enough to be here today. Please share this very important information with your colleagues. And have a very happy and blessed Thanksgiving. God bless you all, and thank you again. I'll turn it back to you, Dr. Denham.
So thank you very much for your attendance, and this ends our November webinar, and in March we will have done our 100th webinar over the last 10 years. So we wish you the best and a happy Thanksgiving.